So what I'm going to do is try to give you a very quick overview of CKD anemia in 2016. The talk is going to comprise of some elements that you probably have ingrained in your DNA now, because anemia has been such a hot topic over the past 10 years or so, and some things which I'm going to give you as a view towards the future. And obviously the things that are going to be a view towards the future are not going to be in the boards. Things that we've done in the past, almost all of those things will be ripe for being in the boards. So I'm going to start with a case history. This is a 62-year-old white woman with a 10-year history of CKD from diabetes, slowly worsening renal function, a past history of a right CVA stroke. She sees you in the office, she feels great, she's working, she's exercising, she's eating well. Lab data shows a BUN of 48, a creatinine of 4.2, an estimated GFR of 18, hemoglobin 8.9, TSAT of 30%, and a ferritin of 282. And so the question is, what do you do in this patient, right? So she's got renal dysfunction with a GFR of 18, she's anemic with a hemoglobin of 8.9, and her TSAT and 30% and ferritin 282. So let me just do this by show of hands, just to get you exercise. This is part of the stretch from the last little stretch exercise. So how many people would start this patient on an ESA? Just raise your hand. Oh, there are about 15 or so, 20 people. Empirically treated with a course of intravenous iron. Just raise your hand. One or two people. And then check stool guaiacs, and if all right, continue to just observe her. Yeah, about 30. So I think the plurality, I think about 50% of the people in this room would choose C. The next most popular is started on an ESA, and the least popular is treated with a course of iron. Now recognize that treating her with a course of iron empirically would not necessarily be the wrong thing from previous recommendations. People have thought that there is this notion of functional iron deficiency, and that perhaps a TSAT of 30% or a ferritin of 282 is masking some underlying deficiency of iron. Also know that about 40% of patients with CKD are iron deficient even if their iron parameters are normal, and this has been demonstrated in studies before. So it's not completely off the wall to say, let me just give the patient a course of intravenous or you could even think of oral iron, but at least intravenous iron. But the correct answer would be check stool guaiacs, and if all right, continue to observe her. This would be my correct answer. Now, I grant you that there is a fair amount of opinion and judgment here, but this would be my correct answer, and we'll go into why I think that in a few minutes. About 5 years ago, to the surprise of virtually everyone in the anemia field, the US FDA came up with an ESA label. This label was essentially in opposition to the advisory committee that the FDA had set up in the wake of the various studies, the TREAT study that was published. And what they said was that for patients with CKD not on dialysis, you should consider initiating ESA treatment only when the hemoglobin is less than 10, and the following considerations apply. The rate of hemoglobin decline indicates the likelihood of requiring a blood transfusion in the context of reducing the risk of alloimmunization and other red blood cell related risks. And if the hemoglobin, and if they said if the hemoglobin level exceeds 10, then reduce or interrupt the dose. So in a sense, what they were saying was 10 is the marker, right? This woman had a hemoglobin of 8.9, you'd say, well, it's reasonable to consider starting her on some form of treatment. But there are caveats, and we'll go into that in a few minutes. The KDIGO Anemia Guidelines, which were adopted by KDOKI, were published in August of 2012. And they came up with some interesting statements, which I think are worth dwelling on for a minute or two. The first was stated in 3.2, which is, in initiating and maintaining ESA therapy, we recommend balancing the potential benefits of reducing blood transfusion and anemia-related symptoms against the risk of harm in an individual patient, for example, stroke, vascular access loss, or hypertension. And that's graded 1B, which is pretty strong. There are very few renal recommendations that get that high a grade. And in the context of our patient, you would say, if she's feeling great, hemoglobin of 8.1, but she's exercising, doing well. The fact that she has a stroke would make you think that treating her is not the right direction to go, especially if she's doing fine. They go on, we recommend using ESA therapy with great caution, if at all. And that's a very interesting use of word, right? If at all. In other words, a guideline, consensus guideline, giving us permission not to treat a patient who's anemic if that patient has certain conditions, a patient with active malignancy, in particular when cure is the anticipated outcome, 1B, and a history of stroke, 1B, or a history of malignancy, 2C. And I bring this out, these anemia guidelines out to tell you that for the 30% or so of people in this room who said they would treat with an ESA, I think you have to, if you believe in guidelines and if you believe in the evidence, you have to say that I will at least be cognizant of the fact that this patient has a significant meaningful risk of having another stroke. They've had a stroke in the past, and if the risk is increased by administration of ESA, then I'm going to be cautious, right? In 3.43 of this guideline for adult CKD patients 5D, we suggest that ESA therapy be used to avoid having the hemoglobin concentration fall below 9 by starting ESA therapy when the hemoglobin is between 9 to 10. For many years while I was practicing, seeing patients on dialysis, I was always told by my colleagues that 10 was the number. Don't let the hemoglobin fall below 10. Here again, guidelines are supporting the notion that you can get the hemoglobin down to 9, and that's okay. Somewhere between 9 and 10 is the band in which you should be starting initiation of therapy and or thinking of keeping a patient on therapy. So the questions that arise are, when should one treat and what hemoglobin should one aim for? In our case, the patient I presented, the answer is no. I think that would be the correct answer. She's not symptomatic, she's doing fine, and also has a history of stroke. Would work up with the anemia, we would work up the anemia and make sure that she's not bleeding. Those would be the common sense things you would do. And remember that there is no evidence that mild anemia treatment is a disease-modifying treatment. You're treating really for symptoms in these patients with mild anemia. And so the notion that you must treat when the hemoglobin falls below 10 is not really supported by the guidelines or by some of the evidence. And I think what I'll do next is to discuss some of the evidence with you. So what hemoglobin target should one treat to? We already discussed somewhere between 9 and 10. You should keep, that's one threshold. The KDIGO guidelines in 3.5.1, in general, we suggest that ESAs not be used to maintain hemoglobin concentrations above 11.5 in adult patients with CKD. Fairly good guideline, 2C. They talk about individualization, and they talk about the fact in 3.6 not allowing the hemoglobin to rise above 13. So now we're starting to get a picture of where the guideline folks want us to manage these patients. So the hemoglobin target, just to summarize this, for treatment by KDIGO would be less than 11.5. And remember, KDIGO recommendations have been adopted by KDOQI. And the FDA would say less than 11, right? So that's one place you can sit. What about the lower number? KDIGO would say greater than 9, and FDA would say greater than 10. So that's the lower number. Many would argue that it's very hard to keep patients between 10 and 11. That's just too narrow a range. Why 9? In dialysis patients, you could argue the evidence from the normal hematocrit study would support 9 as a threshold, and in non-dialysis patients, evidence from the TREAT study. Why 11.5? Well, normal hematocrit study was 9 to 11. 11 was the upper limit. CREATE, likewise, higher was associated with risk, and QUIRE, 11.3 was better than 13.5. So some evidence around targets have now emerged, and there's some consensus. This is the situation in the US. In Europe, the Europeans have not adopted these targets, so that adds another level of complexity. In Europe, it's 10 to 12, and they have not changed, they've not budged. And in fact, the majority of people on the European best practice guideline committee were also on KDIGO, But they rejected their own processes that they adopted for KDIGO and came up with the status quo 10 to 12 in Europe. But KDIGO is different, and mostly in America we've paid attention to KDIGO because it's been adopted by, or been accepted by KDOQI. So that's the target hemoglobin, some overview on who to treat and or when to treat. I want to spend the next 10 minutes or so talking to you about the trials. You might ask, well, why do I need to delve into this much detail? This is too much. And I'd say that if you're sitting for either certification or recertification, you do need to know the trials. There will be questions specific to the trials that will be asked of you, so it's worth paying some attention to this issue. I'm going to focus on 3 of the 4 trials, the 4 randomized trials: normal hematocrit, create, choir, and treat. Create, I just cited there, but I'm not going to spend any time on it because it was a small, relatively underpowered study, which I don't think really has results that one can interpret meaningfully. Normal hematocrit, choir, and treat were reasonably sized studies, which I think add a lot of value to our understanding of what we should be doing. In the normal hematocrit study, which was published in 1998 in the New England Journal of Medicine, it tested the hypothesis that patients with normal hemoglobin of between 13 to 15 will have better outcomes than patients with 9 to 11. So 13 to 15 versus 9 to 11. It was not a placebo-controlled trial. It was a trial testing one strategy versus the other. 1,233 hemodialysis patients with coronary artery disease, or CHF, were recruited in the trial, and the primary endpoint was death or myocardial infarction. Pretty hard endpoints. And what this trial showed was that when you compared low hematocrit patients who were randomized to the low hematocrit arm, 30 versus 42, that there was a higher rate of, a higher number of deaths in the patients who were randomized to the normal hematocrit versus to the low hematocrit, and there were a higher rate of non-fatal MIs. And the relative risk, there was a 30% higher risk. Now, people will look at this confidence interval and say 0.9 to 1.9 goes across 1 and it's not going to reach statistical significance. Subsequent revised analyses actually do not agree and feel that this was a study that showed statistical significance, and that's been accepted by the FDA and is in the label now, that there was a statistically significant higher risk of being treated to the higher hemoglobin in stable dialysis patients with underlying cardiovascular disease. Bottom line is the study showed harm. In choir, 1,432 subjects, it was a US study where Erythropoietin was used, EPO, and these were non-dialysis CKD patients that were randomized to a high target hemoglobin of 13.5 versus a lower target hemoglobin of 11.3. And you see that the achieved hemoglobins, there was some separation. And what we showed was that in patients who were randomized to the higher arm, there was a approximately 30% increased risk of heart attacks, heart failure, and death. And so the death, MI, CHF, hospitalization, or stroke, 125 events versus 97 events, with a hazard ratio of 1.33, which was statistically significant, with a p-value of 0.03. So no debate, I think, that treating to a higher hemoglobin associated with increased risk. The question is it the hemoglobin or is it the exposure to the high doses? If you look at in choir, twice the dose, nearly 10,000 units of EPO on average were used in patients treated with a higher hemoglobin. And likewise, in the normal hematocrit study, you can see that there was a significantly higher dose of EPO used in the patients treated to the higher hemoglobin. Again, is it the hemoglobin that's the problem, or is it exposure to very high doses of EPO? That's the real question. What drove in choir? What drove the bad outcomes? Well, it was death, which is terrible, right? It's not a fudgeable thing. So people have argued, well, I don't know whether the choir study really showed what it showed. Well, there was a 48% higher rate of death if you were randomized to the higher arm. You can't adjust away death, right? I mean, you can't say, well, somebody was dead now, I used some variables and adjusted, and now the person is not dead. These were dead people. There were more people who died in the higher hemoglobin arm than in the lower hemoglobin arm. There was also a higher rate of CHF hospitalization. There was no, while quality of life increase in both arms, there was no difference between the groups. So this is the point, that there was risk shown, but not very much of an impressive improvement in quality of life, which is a meaningful difference. The last of this troika of studies which I want to talk about is the TREAT study. Nearly 20 years after the introduction of the drug, we had a placebo-controlled randomized trial. 4,000 odd patients were recruited, and these were patients with diabetes, chronic kidney disease, and anemia. And they were randomized to either 13 hemoglobin target or rescued at 9. So essentially 13 versus 9, active treatment versus placebo, almost placebo in the other arm. And what you see is for these cardiovascular renal endpoints, no benefit of treatment. No benefit of treatment compared to placebo. So those people who believe that there is a real benefit of treating anemia in patients with kidney disease, you're not reading the literature. You're reading advertisements from pharmaceutical companies saying treating patients with this drug to higher hemoglobins is beneficial with higher doses. We do not know, as I said, still whether it's the drug that's doing this versus the hemoglobin treatment. What TREAT also showed was in patients who were randomized that treatment of patients with darbepoetin resulted in about a 2-fold increase in risk of stroke from all comers. You can see that here, and it was statistically significant, highly statistically significant. So treatment with darbepoetin compared to placebo was associated with an increased risk of stroke. I mean, that's meaningful, right? And what was really striking, and this is relevant to the case presentation I provided you right at the beginning, was if you had had a stroke in the past, there was a 3-fold higher risk of another stroke when you were treated with darbepoetin than if you were treated with placebo. 3-fold higher increase in the risk of stroke. So past history of a stroke increased the risk further, presumably from thromboembolism because of exposure to drug. What about malignancy? Small numbers, but this is the data that suggested that there should be some caution about treating patients who have active malignancy. Among patients who had deaths attributed to cancer, those exposed to darbepoetin had a nearly 8-fold higher risk, 7.4% versus 0.6%, and a p-value of 0.002. Again, quite a significant risk. And these are patients who had a baseline history of malignancy. So if you have a history of malignancy, getting recruited into TREAT, so presumably the malignancy didn't lead to some terminal condition, you were recruited in the trial. If you're then exposed to darbepoetin, you had a risk of dying from the cancer. Was there an improvement in quality of life in 2 domains of energy and physical function? The answer was no. Treatment with darbepoetin was not associated with this. Now, there was another study published where, for another scale, there was some modest benefit that was persistent throughout the time patients were in the trial. But it was, we're talking here about modest benefits. So how would I pull all of this together? I'd say you're seeing patients in your clinic, in wherever it is, non-dialysis patients. When you start seeing those patients, you start seeing the hemoglobin drifting down, starting at 12, down to 11, maybe somewhere between 10 and 11. You should start working these patients up. And the things you should be thinking about are iron deficiency, erythropoietin deficiency, and inflammation. Anemia in these patients is not just EPO deficiency. These are the 3 things you should be thinking about. You should do stool checking for occult blood. And if the patient is likely to have iron deficiency, as defined by a ferritin of less than 100 and a TSAT of less than 20, I think the rational thing today would be to treat the patient with a course of oral iron, at least if they tolerate it. It's worth starting them on that. If they don't tolerate oral iron, then you can certainly consider intravenous iron. If you think they're inflamed, they have some sort of a ulcer, they have an indwelling catheter, they've got a failed kidney, you might have some markers for that. Albumin may be a little on the low side, the ferritin may be quite high, and their CRP may be elevated to greater than 2. you might want to target what's inducing the inflammation. Take out the tunnel line if that's what it is, or try and talk to the surgeon and see if they might take the graft out. In patients who don't have either of these, you will think of likely ESA deficiency as a possible reason. These patients will have normal iron stores, normal folate, no evidence of inflammation, no evidence of occult blood loss. Even here, you might use some judgment. You say, you know what, I'm going to treat the patient with some empiric iron. What's the downside? I mean, that's not a bad strategy, but let's assume that you've determined pretty sure this is not an iron deficient patient. You will start this patient, you'll think about starting the patient on ESA. In these patients, I would say, if the patient's very symptomatic and the hemoglobin is drifting from 11 down to 10, I would start thinking about starting this patient on ESA. They're symptomatic. It's worth giving it a shot. You might improve this patient's quality of life. They're a transplant candidate. You want to avoid them going really low where a blood transfusion may be necessary. So you may want to treat that patient. If they're 9 to 10, which is where most of the patients are, you may let them sit there if they're not symptomatic. And if they're less than 9, and if they've got a history of prior stroke or active malignancy, I'd let them drift all the way down to 9 or less, and then think about starting treatment. In that case, I might use a low dose of an ESA and not use regular dose. So I might start with 2,000 units of EPO or 20 micrograms of Erythropoietin, just a little bit to see if I can get them up a little and see if they improve. That would be what I would suggest is rational therapy. So that's all the stuff you'll need to know for the boards, right? Let's think about where we're going with this. Where are we heading? I'm telling you that we are at the cusp in the next 5 years of heading into areas of innovation that we hopefully will change how we manage anemia, right? And this is that we are going to be heading towards activating endogenous erythropoietin production. That's where we're heading. If I was to imagine what life would look like for the average patient on dialysis or somebody not on dialysis, 5 to 10 years from now, I'd say the opportunity would be an oral agent that they would be taking either every day or every other day. That would be treating them for their anemia, that might be able to mobilize iron, that they'll be able to tolerate, and that we would be able to demonstrate, hopefully, in that period, that it's not really the hemoglobin that was causing all the harm. It was exposure to high doses, and so you can get those hemoglobins up to 12 or 13 or thereabouts. That's where I think, 5 to 10 years from now, we ought to be. So what is this all about? So what we're really talking about is gene regulation, using agents to regulate the EPO gene, to basically pull the clamp off so that now you can get endogenous production of EPO from sources that you would not normally have thought were possible. And this is to use hypoxia-inducible factors, HIF stabilizing agents. And you might say, well, that's just for the birds, right? I've never heard of this, or I don't think this is going to happen. And I'm here to tell you that this is real. This is going to happen. Whether it happens in 5 years' time or happens a little later than that, I'm pretty confident that it's going to happen. And these are prolyl hydroxylase inhibitors. These inhibit an enzyme that breaks down HIF, and HIF is a transcription factor that regulates erythropoietin gene transcription. You don't need to know much more about it other than there are different types of HIFs. What you do need to know is there are a number of companies in this space that are doing research and have now completed the phase 2 phase of their development program and are entering into phase 3. And many of you are going to be in dialysis units or practices where you're going to be sent a questionnaire to say, would you be willing to participate in this sort of trial? There's another group of agents called GATA inhibitors where there's some strategy to inhibit the EPO promoter and increase EPO production. These ones are not yet in clinical development. So what sort of summary information do you need to know about HIF biology that you can take home? First is that Semenza and Wang discovered HIF in 1991. Remember, erythropoietin, recombinant erythropoietin was introduced in 1989. So 2 years after that, a lot of the biology about how EPO works was unraveled by Semenza and Wang. And they identified the presence of a hypoxia response element in the erythropoietin gene, connecting why hypoxia causes EPO gene activation, and that causes the hemoglobin to go up. They identified the different subunits of HIF, and they figured out what the machinery is in regulating the EPO gene. That was progress, right? And basically the bottom line is, you can see this, HIF alpha would normally go to HIF alpha beta as a subunit if there wasn't hypoxia present. So hypoxia is, HIF alpha is prevented from going to HIF alpha and beta, right, in the context of normal oxygen tension. And in hypoxia, there's a clamp. So that HIF1 alpha to HIF1 alpha beta in hypoxic conditions basically causes activation of the EPO gene. So hypoxia is this thing that removes the inability of you to get EPO gene transcription. And essentially, PHIs, these agents, do the same thing. So they basically inhibit this enzyme and result in the production of a HIF alpha beta complex that binds to the HRE subunit in the EPO gene and results in EPO gene transcription. I'm not going to go through the details. It's in this, summarized from this paper by Kant in 2013 that explains all of this, but that's the bottom line. PHIs inhibit this enzyme that in turn inhibits EPO gene transcription. How does this work in the kidney? So in the normal kidney, you have this situation here where you have an oxygen sensing mechanism, right? This is like a hematocrit meter. And in conditions of normal oxygen sensing, you've got suppression of EPO gene transcription and you don't get production of EPO. And in hypoxia, you have that clamp removed. In an inflamed kidney, these cells basically have inflammation, there may be some transient failure, and in the end-stage kidney, these renal epithelial cells that are involved in sensing and producing EPO don't do their job. These HIF stabilizing agents have multiple different actions. And the reason I show you this slide is that obviously in producing an agent, an oral agent that replaces EPO, you got to make sure it's safe. So you got to know what else does it do. And there are many, many actions, but the bottom line is at low doses where you can get EPO gene transcription, you can get that in an isolated fashion, in a targeted fashion, without necessarily getting all the other things like angiogenesis with activation of VEGF or changes in extracellular matrix production, et cetera, et cetera. Are there living examples where if you activate gene production, you can move forward? Yeah, there are some examples. This is in this fairly remote Russian Republic, there is a condition called Chuvas polycythemia, where there is a mutation in this part of the gene, and these patients develop polycythemia. So there is an example of this in a genetic model where these patients actually have unrestrained production of EPO and polycythemia. So this is a real thing, not just something that people made up. In this study published in JASN now almost 6 years ago, you can see that you have plasma EPO levels on the vertical axis, healthy controls, anephric patients on dialysis and nephric patients on dialysis, and you have treatment with a HIF stabilizer. And you see the effect on a dose-dependent effect in healthy controls on EPO production, right? But you also see it in anephric patients, and this production is coming from the liver. These patients have no kidneys, and they're still able to generate EPO production. And in nephric patients, you're getting both production from the kidneys and from the liver. So now you see how these agents can work to produce EPO even in patients whose kidneys are not functioning. They're fibrosed or they've actually been removed. This is a study which represents, this is a paper that represents two studies on an agent that's manufactured by GSK. The previous one was Fibrogen, and basically these two studies and 73 patients were not on dialysis, or 83 patients were stable dialysis patients, looked at different doses of their HIF agent and found that, in fact, it also has a dose-dependent effect on EPO production, and hemoglobins go up in a dose-dependent manner. There's also dose-related decreases in hepcidin and the possibility or the lure of the fact that you may get mobilization of iron as HIF causes effects on hepcidin. So the drug seems to work in the studies that have been done. So what are the pros and cons of these agents, these HIF stabilizers? They're safer alternative to exogenous EPO. Oral agents, they modulate many other genes, notably EPO receptor, transferrin receptor, ferroportin, so they may actually have other beneficial effects like result in mobilization of iron and more iron available. They reduce hepcidin levels, which might improve treatment of EPO-resistant patients. But there are also some concerns. In one of the trials, there was a death from hepatic necrosis in one patient that slowed up the development program. There may be potential effects on angiogenesis, although that hasn't been seen, but these are, you can get activation of oxygen sensing genes. And increased VEGF levels, at least hypothetically, may be associated with increased tumors and renal cysts. And so, that's why you do clinical trials. You balance the risks and benefits, and these trials are now ongoing. At the end of the day, the thought is that if you look at what happens in patients, kidney patients that we manage with exogenous EPO, you get this cycling in EPO levels, right? You give EPO into these patients, 5,000, 10,000 units, get very high levels. If you stimulate endogenous EPO, you get levels that are much lower, 40, 50, whereas the levels with exogenous EPO are in 400, 500, 600 ranges. So really many magnitude difference between activating the production of endogenous EPO versus giving EPO exogenously. So I and a number of other colleagues are working on these type of studies, and we're asking the question, is administration of PHI associated with cardiovascular benefits? What are the other beneficial effects that PHI treatments bring in addition to stimulating EPO production? What about iron mobilization, less hypertension, other factors? What are the risks? Cancer, pulmonary hypertension. Where's the risk-benefit ratio? What you will see happening in the next several years is the implementation and then reporting of results from these different studies. You screen patients, you randomize patients to some form of EPO, whether it's Erythropoietin or Erythropoietin, compare that to a PHI, aim for roughly similar hemoglobin level, and look for cardiovascular endpoints, including death. Right now, there are about 20,000 patients worldwide that are being randomized to these studies. Fibrogen, Astellas, GSK, and Akebia are in this space. I have a gap here for Bayer that was in this space but hasn't gotten going with their phase 3 program as yet. Fibrogen, Astellas is a little bit further along. GSK is a little bit behind them, and Akebia is a little bit behind GSK. So about 20,000 patients will be randomized between 2015 and 2021. And just in the interest of full disclosure, you saw in my disclosure slide that I derive research funding from GSK, and I'm leading the GSK development program. But you will hopefully see something that will be transformational in this field in the next 5 to 10 years. So in the last 10 minutes or so, let me get back to the case again. 62-year-old woman, now we see her 2 years later, following her initial presentation. She feels fatigued with minor tasks, has difficulty getting out of bed, hemoglobin 8.9, iron stores are replete, but she is started on an ESA, and she started on Erythropoietin 40 micrograms each week. Her hemoglobin responds and she feels better. 6 months later, she develops an ulcer on her foot. Her hemoglobin starts to drift down despite a gradual threefold increase in her Erythropoietin dose, which is now at 120 micrograms weekly. So which one of the following statements is correct? And we'll do show of hands. The patient should be started with a course of IV iron. The patient requires blood transfusion. The most likely cause of her ESA resistance is a diabetic foot ulcer. You should not escalate her ESA dose, or she should be treated with an anabolic steroid. These are the options I want to discuss. So how many would say A, give this patient iron? Well, nobody. How many would say, give her a blood transfusion? One person. What about don't do anything? How many people say that? 5, 6 people. Give her an anabolic steroid. Nobody. So the vast majority of people do not know what to do, is that right? You just said you felt B, but you didn't want to raise your hand? Okay. C. All right. Yeah, that's correct. Maybe I'm just not listening. My hearing is not so good from here. So let me just give you a quick thumbnail sketch of erythropoietin resistance. Why do I want to tell you this? Because about 10 to 15% of patients on dialysis have EPO resistance. Whether you define it as that or not, that's what they have. And the problem is, the reason it's so difficult is because we haven't got agreement on how to define it. And I showed you here 4 bullets of 4 definitions, but I only did this because I wanted to keep the slides simple. I could have shown you 2 more slides with 4 more definitions each on each of the slides. There are so many different definitions. There's no consensus, right? Most people would say EPO resistance is defined at very high levels of EPO given per either hemoglobin level, standardized for some hemoglobin level, or standardized for weight. Most of us who practice would say, I know EPO resistance when I see it. I come round on my patients and they're on boatloads of EPO, and any escalation in dose doesn't seem to make any difference at all, right? So it's a combination of just a high exposure to the drug, plus no benefit from, in hemoglobin terms, in treating them with more EPO. Escalating it has no effect. And the TREAT study did define EPO resistance, and that TREAT study, which this paper that was published in the New England Journal of Medicine on EPO resistance, swayed the KDIGO guideline committee to classify patients in the dynamic way, i.e. classify patients as having ESA hyperresponsiveness, that they have no increase in hemoglobin concentration from baseline after about a month of ESA treatment or appropriate weight-based dosing. But they didn't give it a grading. So they use a more dynamic definition, you know, but most of us don't necessarily just use that. We use exposure to high doses at any given point when we see the patient, plus no benefit to treatment over some period of time. I show you the 2 most important causes of erythropoietin resistance. If this was coming up in the boards, iron deficiency is singularly the most important, and then secondly would be inflammation, where infectious and chronic microinflammatory influences prevent the bone marrow from manufacturing red cells. Examples to this might be, or common examples might be failed kidney allograft or chronic infection, various types, either tunnel, catheter, diabetic ulcer, amputation, etc. There are many other causes, but I'd say they're all relatively secondary. You're not going to see them that commonly. They're all there. Of course, malignancies associated with erythropoietin resistance, drugs might be, etc. But the two big ones would be iron deficiency and inflammation. What does KDIGO say about management strategies in these patients? They say in patients with ESA hyperresponsiveness, we suggest avoiding repeated escalations in ESA dose beyond double the initial weight-based dose. And so what I normally do when I see patients in my clinic or I see them in dialysis would be I would not escalate just endlessly. 10,000 units, that's it. I don't go up beyond that unless there's some bone marrow reason why they need to be exposed to much higher doses. If you're just wasting money, it's just not worth it. The second is, when prescribing iron therapy, balance the potential benefits of avoiding or minimizing blood transfusions, ESA therapy, and anemia-related symptoms against the risk to individual patients. And what they're basically saying is, we're not quite sure whether that iron therapy is the right thing in these patients versus transfusing them with blood. I just saw a patient this past weekend who I saw in clinic, severely anemic, and had iron deficiency from having a slow bleed. And that patient, the correct therapy was giving them a blood transfusion, actually multiple units of blood. They get iron through that, it repairs the problem fairly quickly. In that patient, IV iron is not the right therapy. So I think that's one issue. The second issue is, what about oral versus IV iron? KDIGO gives you permission essentially to give a trial of oral iron, and I think it does work. There is some data to support it. I know that patients may not tolerate it. I know that patients may have some side effects, but the data doesn't suggest that it's that bad. I think this is a lot of drug reps going into doctors' offices and saying, you don't want to be treating your patients with oral iron because they're going to get a lot of side effects, and you should be giving everybody IV iron. I don't think that's supported. I mean, we don't do that to pregnant women who are anemic. And these patients pregnant women can't afford to be vomiting and having bloating and diarrhea and all the rest of it. We give them a trial of oral iron. Now, it's low dose, but it's still and we choose different agents, carbon-related iron, and different types of, and there are many different types of iron therapy. I think that's the amount of care you have to give even with the CKD patients. Weigh the benefits of oral versus IV, and don't exclude the fact that they may benefit from oral iron. There are some newer iron therapies, ferromoxetol, which I was involved in publishing some of their phase 3 data, but I do not use this in my practice because I think it's just too expensive. No hospital should be paying this much money for iron, intravenous iron, even though you can give it in a few seconds. Maybe it's okay to, give it over a little longer time and save $400, right? I mean, that's not necessarily a bad thing. Ferric carboxymaltose is approved for non-dialysis dependent CKD anemia. It's worth considering. Ferric is also expensive. Ferric citrate is an oral agent which is well tolerated, has been approved, and it binds both phosphorus and repletes iron. The jury is out on what side effect profile, but it's something worth considering. This is oral iron, ferric citrate. You can actually get ferric citrate, believe it or not, in a generic form. You don't have to buy, tell your patient to buy a Xaranex. You can just prescribe ferric citrate. And then there's another new agent which we published on in the last year or so, which is SFP or triferric, where you put iron into the dialysate. So now you're dialyzing people with black dialysate. Isn't that interesting? How many people have seen that? No, nobody in this room, I imagine. But this is infusing patients with dialysate, which is supplemented with iron, and it replaces the 5 to 7 milligrams of iron lost during dialysis treatment, and it seems to be well tolerated. And I will just tell you a little bit about this SFP only because it's a promising iron agent. I'm not going to give you all the details because I'm a little bit short on time, but I will say that the difference between this agent and the regular IV agents is that this is this is a salt of iron and not coated with carbohydrates. So this iron, when infused into patients intravenously, doesn't go and sit into the reticular endothelial system. It doesn't cause iron predominantly in macrophages and other cells like that. If you look at, there was a paper we published in NDT in 2015, which basically shows that it's well tolerated and it's effective in repleting iron in patients. So maybe that's going to be the future with iron. We walk by, you don't have to think about giving patients IV iron as an infusion. There's a little bit of iron in every liter of dialysate that then repletes the patient on an ongoing basis. So in conclusion, I hope I have enlightened you on some of the guidelines around iron and ESAs. For ESAs, ESA treatment is a symptom-modifying treatment, not a disease-modifying treatment. And I think most people would agree that target should be around between 9 to 11 grams per deciliter. I think that this is a put it in quote marks because I think the jury is out whether it's the hemoglobin that causes harm versus exposure to high doses of ESA, and for the future may change our views on that. Randomized controlled trials demonstrate increased risk with targeting a higher hemoglobin, and you would say that you should try and avoid hemoglobins of greater than 11, use low ESA doses, and avoid ESAs in patients with stroke or cancer history. There are new ESAs that are emerging, and these agents, the PHI agents, I think are going to be something very exciting for the future. ESA hyperresponsiveness occurs for a variety of reasons, the most important being iron deficiency and inflammation. These are high-risk patients. They tend to have higher mortality. In these patients, most of us would avoid ESA dose escalation and, in fact, would try to look for reasons why the patient is hyperresponsive and try to correct that. And then, as I shared with you at the very end, new iron treatments are emerging, including iron that's going to be put into the dialysate to repair some of the ongoing iron losses that dialysis patients experience. Thank you very much. Any questions? Sorry.
Any role of philpotins if the hemoglobin is about 16? Are there any data behind it?
Any role for?
Philpotins, if somebody is a higher hemoglobin without ESA.
Yeah, what do you do in patients with higher hemoglobin without an ESA? I think if they have polycythemia, you manage that. There are, I think about 1% of the dialysis population have normal to higher hemoglobins. These are polycystic kidneys or patients with other sort of, hematological reasons. These patients do not have worse outcome. That's why this notion that, that it may not be the hemoglobin is not supported by that evidence. And in fact, patients at higher altitude, this was shown by Wolfgang Winkelmeyer, patients at higher altitude do not seem to do worse than patients who have a higher hemoglobin level than patients at lower altitudes. So I do not, unless the patient's hemoglobins are very high in the polycythemic range, I do not do anything about those. I just will follow along. Any other questions? Great, thank you very much. Appreciate it.